I'm going to talk about lower extremity PAD interventions. I will give an overview of PAD interventions from access to crossover techniques to specific treatments of specific segments. What complicates PAD interventions in comparison to coronary interventions is that you have different wire systems and different potential access options and access combination. You can do double, triple access, radial with femoral, double femoral, femoral with pedal. So multiple access combinations. There are also 4 separate treatment segments, and always as you think of PAD, lower extremity PAD intervention, think of those. So you have the iliac segment, the femoral segment, the infrapopliteal segment, and the 4th and the last frontier, the infra-ankle segment, which consists of the dorsalis pedis, the pedal loop, and the plantars, which are branches of the posterior tibial artery. So I will start with general access. Access in general for diagnostic angiography and intervention is usually femoral contralateral. I do my diagnostic angiography and intervention in the same setting. So, imagine we're taking a patient with left lower extremity claudication or CLI. The non-invasive testing has geared you in one direction as of where the disease is, but regardless, grossly, if I want to give you one simple approach that applies to the majority of the cases, is that you start your access femoral contralateral. There are 5 different accesses, but this is the most common classic one. The only one common iliac disease may be treated, for example, if you have an ostial common iliac stenosis, this one may be treated through an ipsilateral access, but it still often requires contralateral access. And you may start with a contralateral access for imaging, for mapping the ipsilateral access, and for wire protection during intervention, and for mapping the ipsilateral access and maneuvers during ipsilateral intervention. So the starting point is usually contralateral access. Common iliac may often requires bilateral femoral access. Even if you treat it ipsilaterally, you often need a contralateral access for imaging and guidance. Okay. So typically we start with a contralateral access. Let's say we have left lower extremity claudication. We're starting with the right common femoral artery. We start our imaging with this catheter. So we start with a 4 to 5 French sheath in that common femoral artery here. And we use this omniflush catheter, which is a multi-holes catheter. We position it in the distal aorta and we do our first image. So you start with a 4 or 5 French omniflush catheter, and the basic angiography is obtained as following. If you're doing your imaging below the renals, which is the way I do it typically, you inject 10 milliliter per second for a total of about 20 milliliter, give or take. If you're doing your imaging above the renal level, which is around L1, then you give more because you fill the renals and some of the mesenteric and lumbars. So you give 15 milliliters per second for a total of 30 milliliter. You load your injector with this 30 milliliter and 15 milliliters per second. And typically, I'm not doing too much renals anymore because there is rarely a need to intervene there. So I use that equation most often, and I position it low, and I get good images of my iliacs. So typically, this is an AP view. We use digital subtraction angiography that neutralizes and eliminates the bone and to a good extent the bowels. And after you do this image, the goal is to get selective imaging of the left lower extremity in this case, which is where we might intervene in this patient with left claudication. So after I do this image, I do what we call overlay or smart mask, meaning we use that digital subtraction image, we save this frame, and this frame gets saved not just as a reference, but it gets saved as a background of your live fluoroscopic manipulation. so that it guides you to gear your devices appropriately to the left side, okay? So it gets superimposed on your live fluoro and it helps you gear your devices. And the beauty of that overlay is that you can adjust the intensity. You can loosen the intensity so that you see your gear, your wire and catheter that you're actively advancing, or you can intensify it if you want to see more where the branches are in that subtraction in geography. Okay, so after we obtain our image, this is what I do next. So my goal is to get to that common femoral and do imaging, then later intervention. So using that OmniFlush catheter that is here, this is what I do. I try to wire the contralateral limb while that OmniFlush is positioned in the distal aorta. I use the overlay image to help direct my wire into the contralateral limb through the OmniFlush catheter. So I torque the catheter, I make it look toward this direction, and I advance the wire. We use a glide wire. It has to be a slippery glide wire that can slide through and not prolapse out as you're doing those maneuvering. And the moment that wire kind of gets into the iliac with some distance in it, you pull, and as long as your OmniFlush is looking in the right direction, you pull the whole system till it embraces that aortoiliac bifurcation. Then you advance the wire furthermore, that slippery glide wire furthermore, using your DSA overlay. Then you advance the catheter furthermore into the common femoral artery. I like to use the OmniFlush to do those maneuvering because I can eventually use it to inject. I like the multi-hole feature of it. But at the beginning of your career, if you find this difficult to use, you may use an IM catheter, which is easier. It's easier for the IM to embrace that bifurcation. It's easier to handle that than spreading out that OmniFlush catheter. Either way, so I get my catheter down over the glide wire, a soft angled glide wire. Then once I get it around the common femoral artery, I take the glide wire out. Then I'm going to do my imaging of that left lower extremity, a femoral-tibial runoff through that OmniFlush. And the way I do it, I inject, remember here, you're filling the aorta earlier on. You need a bigger volume and a bigger pace of contrast to fill that aorta. You're filling the lower extremity, you need a slower pace, and the total volume depends on the height of the patient and how much you expect his vessels to be large and how much you need to fill that lower extremity compartment. Typical number is 5 milliliter per second for a total of 20 to 25 milliliter in your injection or in your assist system. The way I do that part, I do it without subtraction. Typically, I just run the table with no subtraction, from femoral artery to the toes in an unmagnified fashion. Then I may do focused digital subtraction in geography at specific level, using, for example, 4 milliliter per second for 10 milliliters or so at specific levels. Sometimes if somebody has infrapopliteal disease, what I do, I advance the catheter and he doesn't have SFA, let's say, I advance the catheter all the way to the popliteal, and I do selective DSA of those infrapopliteal vessels using much lower volume of contrast and much better image quality. Okay. So I obtain my images. So what's the next step? Remember, we need to intervene. So the next step is to now try to get our crossover sheath, which is one of the most important and basic steps in peripheral intervention. Get that crossover up and over sheath into the left common femoral artery. So through that OmniFlush or IM catheter that I use to obtain images, I advance a supportive wire. You can, in order of support, you can use a woolly soft tip wire or a Rosen J wire or Amplatz wire. So I advance that wire, and over it, Then I take that catheter, and over it, I advance that crossover, typically 6 or 7 French sheath, 45 to 55 centimeter. And I position it in that, around that common femoral artery. Okay. Classic names are the destination Terumo catheter, 45 centimeter, and the Cook-Rabi catheter. Destination is more soft and slippery. Cook is more stiff, probably provides a little more support. In terms of wire, like I said, you need a more supportive wire. I don't advance this sheath over a glide wire. I advance it over those. Now, if you're having hard time advancing those a little more distally, you can use before that, you can use catheter and wire manipulations to get your wire distally, your Rosen and Woolley wire distally, then you advance the sheath over it. Or you can use a stiff glide wire, which is slippery at the tip, but supportive at the body. You can use a stiff glide wire to advance more distally, then advance the sheath over it. Or you can use something called the glide wire advantage, which has the tip of a glide wire. It's slippery. It can be advanced more distally to give you support for that sheath. It has the tip of a glide wire, but it has the body of stainless steel. So it can go distally, and at the same time, it has a robust body to support your sheath in cases where you have hard time navigating the wire more distally for that sheath advancement step. So this is an example here of an angiogram, an aortic angiogram. So your eyes need to start catching. So we see the aorta, we see the iliac, common iliac, external iliac. It bifurcates into external and internal iliac artery. Then on the right side, on the left side, your eyes have to catch something. In all peripheral interventions, your eyes have to catch late filling distal reconstitution. So somebody inexperienced may miss what's going on here, but he shouldn't miss that there is something filling late here, which is the common femoral artery filling late. So that's your hint that there is an occlusion actually of the external iliac artery. And what you see here, you see just the internal iliac, which is reconstituting through multiple collaterals that common femoral artery. So the external iliac artery is occluded. And in order to highlight this better, what we did, I did the maneuvers I described here. I got my catheter selectively into the common iliac artery. We get that omniflush catheter here, and I did selective image of the iliac artery. And the best image to open up the iliac bifurcation, unlike the femoral, is a contralateral oblique. Okay, so we did an RAO view, and that RAO view displayed it very nicely. So you see the internal iliac. This is the internal iliac, and this is where the common external iliac should be coming here. Okay, it's occluded at the very ostium with a tiny stump. And then you see the reconstitution at the common femoral artery. Okay, so contralateral oblique. Your eyes need to catch distal late filling reconstitution. This is another example. Again, on the right side, you see external iliac occlusion and the internal iliac reconstituting the common femoral. A lot of times, the reconstitution of that common femoral occurs through the inferior epigastric, which we use during our general femoral angiography to localize the external iliac artery and how high our stick is. So a lot of time that artery is good for collaterals. Another way collaterals happen are via the superficial circumflex artery. This is a branch that you should be familiar with when we do femoral angiography, and the micropuncture wire can go into it inadvertently and cause a perforation. So it's an important branch. Anyway, I want you to see through this image two things. So when we want to splay the common femoral artery bifurcation into profunda and SFA, we use ipsilateral oblique. When we want to splay common iliac, external, internal iliac, we use contralateral oblique. So RAO is what's showing us that bifurcation. Another thing on this image, notice also how a general idea that I hope you already know. Notice how the common femoral at the level of the inguinal ligament and that inferior epigastric loop dives deep in the pelvis. This is when we call it external iliac. And that's why sticking the external iliac is so risky, because you're in the loose pelvis, deep in the loose pelvis with no bone support. That's why stick here has a high risk of bleed, RP bleed. Also on ultrasound, that's how you identify. You know, a lot of people know how to identify during ultrasound sticks, the SFA and the profunda and the common femoral. They don't know how to identify the external iliac. They don't know how to identify that, is my stick too high? And the way you identify that by ultrasound is the point where you see that femoral artery dips deep, start to bend abruptly, deeply. This is the point of the external iliac artery, and this is a point you should avoid sticking. Okay, this was a note on the side. Little more anatomy illustration. So this is here an illustration of the femoral artery. So this is a femoral angiography. This is the common femoral here, and you see filling of a vessel. Then again, late distal filling, late distal reconstitution. You should realize that this is not an SFA. The SFA is missing. And if you didn't know that, you will see, you will at least recognize it by the fact that there is late distal filling. So, and here I'm tracing for you where the SFA would be. Two features help you recognize an SFA from a profunda. And this image illustrates that. The SFA curves away from the femur. So this is the femur here, it's a right leg. The SFA curves away from it, whereas the profunda curves towards it. A second feature is that the profunda gives a lot of branches in the thigh. It supplies the thigh muscles, whereas the SFA doesn't give any branches at the thigh level. Okay. So this is just an illustration of the anatomy. Again, common femoral has that inferior epigastric and superficial circumflex femoral artery. Now, this is another case. I want to illustrate to you some difficulty during those steps. You know, you might encounter difficulty advancing your devices up and over, and that's not uncommon. So this is a case of a very tortuous and calcified aorta. You want to get your gears, your wire, and your omniflash catheter up and over into the common femoral artery. That may be difficult across this. So here you need to use more steps to get down there. So one, as we start in this illustration, we start with the omniflash and with the soft wire. Okay, so we make that soft wire slip. Now, over that soft wire, you try to advance it as distally as you can. You try to advance the omniflash catheter. After you pull it back to embrace the aortoiliac curvature, you try to advance it and use 4 French, definitely not 5 French. If it doesn't go, you may need to use even a softer 4 French catheter, like something like a glide cath. So you advance the wire and a 4 French catheter. But in this case, you're not going to be able to advance inside that 4 French catheter. You're not going to be able to advance a stiff wire. You try to advance a stiff wire, it will kick everything out. Try to advance a stiff wire, it will kick your whole system out. So you may need to do it progressively. So soft wire, then soft catheter as far down as you can. Then through it, you advance a stiffer wire, such as a regular J wire. Then over that J wire, you exchange for a slightly stiffer catheter, for example, a 5 or 6 French diagnostic coronary catheter. Then if you get this down, then you get a stiffer wire, such as M-Plats. You have enough support through that catheter to advance stiffer wire. Then your stiff sheath. So soft wire, soft catheter, medium stiffness wire, medium stiffness catheter, then stiffest wire, stiffer sheath. So we add extra steps here, more wire and catheter exchange, more progressive between soft to stiff. So all this to get the sheath to the common femoral artery. The sheath is your base of operation. It's like your guiding catheter in coronary PCI. Okay. And it's important to know this. Sometimes, most often we advance the sheath and we do our manipulation through the sheath, but sometimes we do put a guide through that sheath to provide extra support. So we put a 6 French sheath and we put a coronary 6 French multi-purpose or JR4 guide through it to give us extra support. We call this telescope technique. But you need to know this. When we say 6 French sheath, the inner diameter is like a +1 guide. So 6 French sheath is like using 7 French coronary guide in terms of inner diameter. Conversely, if you put inside that 6 French sheath a 6 French guide, the inner lumen of that 6 French guide will be like 5 French sheath. That's important to know because all our peripheral devices, the boxes and the IFU mentions what sheath you need. So if you put a 6 French guide through that sheath, you need to know that 6 French guide is as if I'm having 5 French sheath. So a lot of the 0.35-inch stent and devices may not go through it anymore. So keep that in mind. 6 French sheath is like 7 French guide. So always sheath is a +1 guide. So I'll describe now more specific segments, okay? I will start then with SFA interventions. So we've positioned our sheath up and over, let's say 6 French sheath, 55 centimeter. Through the sheath, we advance 2 basic systems. Again, most often we don't put a guide. We just advance 2 basic 0.35 systems. We advance the glide wire, typically angled, stiff body glide wire. The tip is soft and angled by the body, but the body is stiff, 0.35-inch. And we advance a quick cross or Navi-Cross catheter, which is like what we use in the coronaries, fine cross or Corsair. It's the support catheter, also 35-inch, which comes in straight and angled tips. Now we'll focus on crossing a total occlusion, which is the most common and most interesting type of intervention. So we cross that total occlusion using a wire loop or knuckle, and you keep it tight. You don't want that wire loop to grow. So you use a wire loop, you push your loop progressively while keeping that quick cross catheter very close to the tip. 1, to give you the best support. 2, to prevent that loop from growing too big. When the loop grows too big, your subintima can become too big if you're going subintimally, and it can prevent you from re-entering. That subintima will eventually grow too big and collapse your reconstitution point. Okay, so we cross with that tight combination, and at the reconstitution point, using roadmap or smart mask imaging, you know you're at the reconstitution. You try to direct your wire and or catheter to poke through into the true lumen. Okay, this is an illustration. So this is a total occlusion of that SFA. We advance subintimally using quick cross and wire knuckle, angled stiff glide wire knuckle. The reason we use angled stiff glide wire rather than angled soft is that stiff body. So as you're pushing the knuckle, the tip is soft, but the knuckle bend is stiff. So it gives you more pushability, and the body is stiff. So it gives you more pushability into that subintima. So you push. Once you reach close to the reconstitution point, you stop. You don't want to keep pushing deep and expanding the subintima deeply. You want to try to re-enter just at that healthiest point of reconstitution, okay? Most often in the periphery, you don't need re-entry device to re-enter. You can use just your wire maneuvering, you can get through. Another thing you can use, you can change a wire. You can use from angled stiff glide wire to straight stiff glide wire. You can change your catheter. So instead of quick cross, I may get a 4 French or 5 French IM catheter, a sharply angled catheter too. And I torque it under fluoro using the roadmap imaging. I know where my true lumen is, and I torque it this way, and I try to poke with a straight stiff glide wire and get through. So that's how we try to re-enter. If this doesn't work, there is a second technique and a third technique. A second technique is to use a retrograde access, a tibial access, and try to cross retrogradely. Sometimes crossing retrogradely is more favorable. So you go retrogradely, you'll end up in the true lumen, and that's it. Or you go subintimally, retrogradely, and then you make the two subintima communicate. Sometimes they just spontaneously communicate in light of their bulk. You have bulky catheters here, they will communicate if they are close to each other. Once they communicate, you make the wire go into that subintima created in one, and that subintima we know communicates with the common femoral. And this is what we call reverse cart. So retrograde, you will end up going through lumen via reverse cart. Another technique, you may balloon antegradely to make those two subintima communicate. This is again a reverse cart via balloon. So the second technique then, if you're not able to recross and re-enter, is to use tibial access. And in that case, you get true lumen via tibial access, then you snare your devices or get them retrogradely into your antegrade sheath, and you can finish your procedure antegradely. The third way, and here in regard to the tibial access, you can tell sometimes by looking whether you need tibial access. This patient, for example, he has a very bad proximal entry point, but he has very nice reconstitution. It's easy to re-enter when you have large reconstitution point, because the subintima is not going to collapse it, and you have a nice landing zone for your re-entry wire. Okay, it's easier to re-enter into a big vessel that is not collapsed by the subintima. Conversely, it's hard to re-enter here. Whatever subintima you create as you're crossing will collapse that distal SFA reconstitution. And the more you try to re-enter distally, the more it will get collapsed. So it may be hard to re-enter here. And those are cases where you may need tibial access with recanalization retrogradely or via retrograde reverse cart. The third technique to re-enter is what we call this, a re-entry catheter. This is from a case I did. Re-entry catheter in the periphery, this is outback catheter. It's a needle. You fire a needle, okay? You use your roadmap imaging, you position your catheter appropriately to be on top of the vessel, not on the side, on top of it. And then you fire your needle. It's a hollow needle that accommodates an 014-inch wire. You fire it, and then you advance inside it the 014 wire. I will describe this in a later session. There are two of those devices, Outback and Pioneer IVUS re-entry catheter. So I described SFA interventions, okay? Now, in terms of iliac interventions, I will split them in two, external iliac and ostial common iliac. So for external iliac plus or minus distal common iliac, we do the same thing. We use a crossover maneuvering like we do in SFA. We position our sheath the closest possible to the point of occlusion to get the best support. And through it, we advance the same 035-inch devices, angled Navicross or straight quick cross catheter, 035, and angled stiff glide wire, okay? Now, as it is with SFA, if we cannot cross, let's say here we have an external iliac occlusion. If we cannot cross it, we end up in the subintima. We cannot re-enter into that common femoral artery. You may need combined ipsilateral femoral and contralateral femoral to do the same thing, retrograde recanalization or reverse cart. Or you may need to do ipsilateral common femoral and radial. So instead of doing contralateral femoral, you may use radial access for crossing or for reverse cart. Okay. So for ostial common iliac, it's a little different because ostial common iliac, as you can imagine, it's easier to cross from an ipsilateral access than to do up and over because you don't have enough support to cross it, and it's hard to stent it and position the stent properly at the ostium of the iliac artery. So when you have ostial common iliac, it's more easily typically to be treated via ipsilateral access, especially to stent appropriately and stent with a stent hanging a little bit in the aorta. So you treat it ipsilaterally. But we use a contralateral access, like I said, for image guidance and for wire protection. And a lot of time those patients have bilateral iliac arteries and you get a plaque shift, and you may need to do a kissing stent. However, in difficult common iliac arteries, common iliac, ostial common iliac that's occluded, and ipsilateral access is often not enough, because you try to cross, your wire goes subintimally into the aorta. So actually, in those cases, you need contralateral access, not just for guidance and protection, but also for crossing to do antegrade-retrograde decanalization. So ipsilateral and contralateral for reverse cart, and or sometimes you may use ipsilateral and radial, like we talked about in the external iliac artery. Here you may do contralateral, ipsilateral, or you may do ipsilateral and radial if needed. Same thing here. You may need to do ipsilateral and radial, or ipsilateral, contralateral in complex cases if you're not able to cross it ipsilaterally. Okay. One idea about iliac, very important to know. It will help you a lot in planning your procedures. Iliac CTOs are more easily crossed antegradely, going this way than going that way. Partly because that proximal cap tends to be softer, and it tends to be convex in a proximal fashion. So if you try to cross from here, your wire will deflect like this subintimally because it's concave here. So it will slide and go this way. Conversely, if you go up and over, if you go, which is antegradely, your wire may be able to stay centered. Besides, the cap is softer usually. Okay. So for those reasons, a lot of time when you have iliac CTO, you almost have to think, I need to do something antegrade. So if your iliac CTO is external iliac, great. That crossover that you start with will work. And if it doesn't work, you'll stick ipsilaterally and do, like we said, ipsi contralateral / cart. For common iliac artery, you try to cross, but oftentimes when it's totally occluded, I know I'm going to need the contralateral access to help me cross. Okay. So even for ostial common iliac, when it's CTO, contralateral femoral access or radial access is needed for crossing because of this concept. Now it's hard to, how do you cross when it's a flush ostial occlusion? How do you position those contralateral gear or the iliac gear or the radial gear, I mean? So use calcium to gauge where to poke your antegrade devices in the ostial CTO with no stump. Also, you can use your retrograde devices, even if they went subintimally, you use them to gauge where to poke. A radial tends to be easier in those cases simply because imagine you put a radial multi-purpose guide, it tends to embrace that curvature better, and it tends to be more centered over the occlusion, whereas contralateral can whatever device you're putting here, let's say a 6 French IMA guide, it will tend to buckle each time you try to advance device. It will tend to buckle up. So it's hard to get support with a flush occlusion. But if you're careful and patient and using a glide wire, you'll eventually be able to find a channel with a wire, push it through, then advance devices over it, even with a flush occlusion. I will show you more cases in the next session, but I'm just laying the ground here. This is an example of a patient. He has severe right common iliac stenosis, and he has total heavily calcified proximal to ostial left common iliac occlusion with a patent external iliac and internal iliac. So here I used what I mentioned to you as a telescope technique. So I put 6 French sheath, and inside that 6 French sheath, I placed a 6 French IM guide to give me enough support to be able to cross that occlusion from an up and over axis. By the way, I tried. So initially in this case, I stuck the contralateral femoral under ultrasound guidance, and I tried to cross via the left femoral. But as I said, oftentimes when it's occluded, that ipsilateral axis oftentimes cannot cross. You go subintima in the aorta. So in that case, I decided to try to cross and do that ipsi contralateral combined technique. So I placed a 6 French sheath, supportive sheath, then threw it a 6 French IM guide to embrace that bifurcation. And through it, I pushed the glide wire and a quick cross catheter. You see, it's hard to see the body of the quick cross catheter. It's probably here. I was able to push them through. Then after I pushed them deeply, I was able even to advance the IM guide through it. Then I ballooned that area. And after I ballooned that area, then it was easy. I had already recanalized it. You could potentially snare it through the ipsilateral sheath, but better yet, since I've already opened it, why snare and rework my way? The better thing is here, since I've opened a channel already with my balloon, I just recrossed ipsilaterally now using a quick cross and glide wire through lumen, okay? Since the contralateral already created a channel for me. Then I finished the procedure ipsilaterally. Again, you could have alternatively snared that wire into that ipsilateral sheath, snared it, got it out, then eventually worked over that wire, eventually exchange it, but over that sort of wire that have been snared and stent and proceed ipsilaterally. This is another case, this one an external iliac artery. So we positioned our guide in the distal common iliac artery. Inside it, we advanced, this was a sheath, we positioned it here. Inside it, we advanced the guiding catheter to get extra support. And inside it, we advanced the quick cross or 35-inch support catheter. And inside it, we advanced that glide wire to cross. This is the supportive 4-element telescope. You need to know that in all complex SFA intervention, complex iliac, but also SFA and infrapopliteal interventions, you need that 4-element telescope. So you put a sheath, which is our base of operation. In simple cases, sheath, then catheter and wire are enough to cross. But in complex cases, you put a sheath. Inside it, you put a guiding catheter, typically a coronary guiding catheter, in this case, IMA. You can use a GR4 or multi-purpose, it's fine. Then inside those, you advance the quick cross or 35-inch and the glide wire. This way you get a lot of support, okay? Now, so I described SFA, iliac, common iliac, and the fourth thing I'll describe is the infrapopliteal disease, how to treat infrapopliteal disease. So this is one way of treating it. So you get your crossover 6 French sheath, the green one, as we did in the SFA interventions. Here, we get this one. Then when we're doing infrapopliteal, I use almost systematically, I use that telescope technique. So I don't just put the sheath and try to cross the infrapopliteal vessel. I put the sheath, then inside it, I put a guiding catheter that I advance distally, and I position it distal SFA or popliteal, depending on the size. I try not to be damp and occlusive. So I put inside that sheath a 5 French guide or a 6 French guiding catheter, taking into account the size of that SFA and popliteal, and I position it distally, and that guide becomes my base of operation. And through it, for the infrapopliteal system, this is where we use not all 35-inch systems. Now we use, through that guiding catheter, we use 014, 018, or 018-inch catheter and wire system, okay? Here is a case of an occluded posterior tibial artery that we want to cross. So that's what we do, that 4-element telescope, sheath, 5 or 6 French guide, and through it, the 014 or 18-inch catheter and wire system. Through a 5 French guide, which is like a 4 French sheath, you can advance a lot of the 014 or 18-inch catheter and wires, okay? Especially what we call the CXI catheter by Cook can go through a 5 French guide, which is a 4 French sheath. Those are things you need to learn as you do more procedure, what fits what. It's not as intuitive as in coronary interventions. Now, imagine though, crossover is not oftentimes is not ideal for complex infrapopliteal interventions. Imagine this patient with heavily calcified and tortuous aortoiliac. That crossover sheath will be providing you with very little support, okay? Because you lose, as you're trying to push here catheter and wires, a lot of the pushing you're doing will be transmitted this way, especially in an aortoiliac that's so tortuous. So a lot of the pushability will be lost in those bands. So you're not going to have a lot of pushability. And what will happen each time you try to push here to cross, the up and over sheath, that green thing, and the orange one, each time you push, those will buckle up in the aorta and everything will jump out. It happens so often when you have such a complicated aortoiliac. So in those cases, the best thing to do is to do antegrade access. So you stick the common femoral artery antegradely this way. You put a short sheath in it, 5 or 6 French antegrade sheath, and through it, you put 5 or 6 French guide, and through the guide, you do your 0.14-inch catheter and wires, okay? And this is how we do antegrade stick. So you want to stick, ideally, theoretically, in an antegrade stick, you stick the common femoral artery this way, and you position the sheath this way, okay? This way, and you position your sheath this way. Now, here's what happens. When you stick the common femoral artery, your needle and wire will tend to go in the profunda. That picture is very nice, illustrates it very nicely, because the profunda goes posteriorly. That's why profunda stick is usually a horrible stick, because the profunda goes posteriorly into the thigh and you cannot obtain hemostasis. It's deep in the thigh. So, and when you're trying to stick antegradely, because you're sticking this way, the needle will tend to go posteriorly into the profunda. So your wires and devices, and actually even your sheath, will tend to go in the profunda. It's a difficult stick if you shoot for the femoral artery and try to gear your devices into the SFA. You may frequently overshoot and end up sticking the profunda. So I've learned with time to just stick the SFA, the proximal SFA, and save my heart a lot of trouble trying to be perfect. So I often stick the SFA by ultrasound. I see the SFA and I stick the SFA and I put my gears in it. Okay. And actually, I looked at series of antegrade femoral access. In close to 65 to 70% of the time, even in series, not just myself, operators use SFA stick. The problem is closure here, and you oftentimes need to use a closure device. I used to use Minx closure under ultrasound guidance to close those, but you need to be ready to do up and over or transradial balloon occlusion if your closure fails. So here is some infrapopliteal anatomy for you to know. First, the popliteal artery. Know that the SFA runs into the medial thigh, and it reaches a point called adductor hiatus, and at the adductor hiatus, it becomes popliteal artery. So the point that is popliteal artery is not the knee joint. It's way above the knee joint. The popliteal starts way above at that adductor hiatus. Fluoroscopically, the adductor hiatus is the point where the SFA meets the bone, the femur, in an AP view. So it's way higher than the knee joint. This is where the popliteal starts. It's important to know for bypass purposes, what we call Fempop above knee is in this area. But also when you stent, this is an area of high bending and stress, and an area of high fracture risk for stents. So the popliteal starts here, and it runs posteriorly, and it's divided into 1, 2, and 3 segments. 2 is around the knee joint, 3 is below the knee joint. So it runs posteriorly, then below the knee, it gives those 3 branches that you need to know well, the 3 infrapopliteal vessels, laterally to medially, AT, peroneal, and PT. So the also anteriorly to posteriorly, the AT is an anterior branch. It comes off the popliteal, it pierces through the interosseous membrane, and it emerges anteriorly, whereas the other 2 remain posterior. Okay. Typically, those triple branches, they don't come as a trifurcation. They come as a double bifurcation. You get AT, then you get tibio-peroneal trunk, which gives peroneal and PT. Very important anatomy to know. Occasionally, though, you have variants. So you may have a trifurcation where you get a point with AT peroneal PT. That's not common, though. Or you may have a very high AT takeoff. Actually, I've seen many cases where the AT comes from from above the knee joint, from that number 2 area. Okay. This is an illustration of that infrapopliteal anatomy, right leg. So AT, peroneal, and PT. I want you to know that distally, to make things more confusing, they crisscross in an AP view. So the AT becomes a little more medial than the peroneal. The peroneal becomes eventually the lateral-most artery, and it supplies the lateral calcaneum. Okay, just know that. This is an angiogram of infrapopliteal extensive occlusion. So here I want you to recognize, so this is a distal popliteal artery, and this is in the subtraction angiography. In this maze of occlusion and collaterals, always guide yourself by the proximal cap and the distal reconstitution. Look for that late distal filling reconstitution, and look for wherever the contrast hangs proximally, and between those two, you know where your occlusion is. Okay, then you can take more magnified images to further localize your proximal cap. Okay, usually for infrapopliteal, I mentioned for iliac, to splay the external and internal iliac, you use contralateral view. For the infrapopliteal, it's ipsilateral usually that splay those 3 infrapopliteal vessels, partly because the leg is often externally rotated in a resting position. So you put ipsilateral oblique, will put your eye image intensifier just over that leg and splay those vessels out. Okay. This patient has a PT reconstitution, and he has actually an AT reconstitution that is less robust. Okay, this is the AT. It occludes somewhere here and it reconstitutes. PT is hard to tell where it's occlude. You need more images here, and you see where it reconstitutes. Okay, this is another case. Here the AT is occluded. You see the PT. You see the peroneal, but don't think this is it. The peroneal occludes. Don't think this is the peroneal here. The peroneal occludes somewhere here, because the peroneal tends to go, like I said, laterally, not medially. So this peroneal, it occludes. And we do this in an ipsilateral oblique to say that enterolateral spread. But you can do also contralateral to see as if you're doing a lateral view of that leg and foot to splay the entero-posterior spread. So you can see that posterior tibial giving the plantar artery, the lateral plantar. You can see also the peroneal here reconstituting via the PT, via that posterior perforating branch. The peroneal is an interesting artery. It has posterior communicating branch with the PT, and it has an anterior perforating communicating branch with the AT. That's why in patient with occluded both PT and AT and patent peroneal becomes their PT and their AT practically via those 2 branches. So it's important to know what role peroneal plays in complex infrapopliteal disease. This is just another case of anatomy, severely diseased right leg, severely diseased anterior tibial and occluded posterior tibial. I recanalized this actually via an anterior tibial access. I recanalized it up and over via anterior tibial, that posterior tibial. This is a lateral view of the foot, so contralateral view of the foot. So for the foot, I like more, for the leg, I like ipsilateral, but at the foot level, I like contralateral view, which is like a lateral view of the foot. To see this, you see the posterior tibial giving you lateral plantar, which is usually the largest, and it's the lower one, and medial plantar. The anterior tibial will give you other branches that I will show here. So this is another case that I did. So this is the posterior tibial. It's giving you medial plantar and lateral plantar. You see the peroneal here giving you going laterally and posteriorly and giving a calcaneal branch. You see the anterior tibial here, it's occluded, but the anterior tibial gives you the dorsalis pedis and the lateral tarsal artery. Those two, the dorsalis pedis and the lateral plantar, communicate via the pedal loop, which is what I mark here. It is lost in this patient. The pedal loop is occluded. Okay, that pedal loop is very important in CLI recanalization. It's important to have a preserved pedal loop. This is another case that I did. The patient has a good PT and peroneal. He has good plantars, however, poor pedal loop, and the anterior tibial is occluded, okay? Or sorry, not occluded, but very severely diseased. So that's why he had an ulcer on the top of his foot, because disease anterior tibial, and even though the PT is great with a good PT pulse, no good communication. So what I did, I recanalized the AT and I recanalized that pedal loop to allow that foot ulcer that is here to here. Okay, so DP lateral tarsal on top from the AT and medial plantar, lateral plantar. So to summarize just the wire and device system we use. So we use 035-inch system, catheter and wire for crossing iliac and SFA, although we may use 018-inch in selective cases, and we have to use 014 when we swap for atherectomy. Both the two types of atherectomy, directional and orbital atherectomy, are over 014-inch wires. So for infrapopliteal, however, we typically use 014-inch system, catheter and wire, but we can sometimes use 018-inch in difficult cases to get more crossing and pushability. Devices in the periphery, unlike the coronary, are over the wire most often, but we do have monorail system as well. This is an illustration, 035 for iliac and femoral most often, 014 for infrapopliteal. The most common wire is that stiff body angled glide wire with 035-inch support catheter. Below the knee, my favorite 014 and 018-inch wire is what we call a glide wire advantage. So it's a glide wire at the tip or in the last 20 centimeter of it, but it's a stainless steel body. That's the glide wire advantage. But you can also use coronary polymer wire like Fielder FC, Fielder XT, Confianza, or Astato. You can use those. And you can use 018-inch glide wire gold, which is a full glide wire. Okay. Those are the catheters for crossing. Those are some names and some examples. They can come in straight and angled. Navicross by Terumo is typically the most classic angled crossing catheter. Those are some of the guide wire. When we talk peripheral guide wires, they come into this. They can come straight, angled, or J wire. The most commonly used are those, angled. Again, angled stiff body glide wire. And they come in this. So beside the tip, the body, is it soft or heavy, stiff? And they come in 035, 018, and 014. Okay. And you know, the classic one is stiff body angle glide wire. Now, after you cross your occlusion, we exchange for a supportive wire. Even in SFA, you cross your occlusion with stiff angle glide wire. Good. Now we're ready to stent and balloon. We exchange for supportive wire and safer wire in terms of perforation. Rosen, Woolley, or Amprads. Most commonly, I use those two, Rosen or Woolley wire. This slide, I want to give you a summary. Once we cross that SFA iliac or infrapopliteal tibial vessel, what devices do we use? There are a myriad of devices. Unlike in coronary where, okay, we cross our stenosis, we do balloon, then stent, standard balloon and standard stent. Here is much more complex with a lot of options. Stenting, I will give you, is not the standard approach in femoral and infrapopliteal disease. Stenting is a standard approach in iliac disease, but not in those two. So for iliac disease, for common iliac, we use balloon expandable stent, like the type of stent we use in the coronary. It's you inflate it with a balloon and it gets opposed to the wall. Conversely, for external iliac, we can use balloon expandable, but we use also self-expanding stent, which is what we use in SFA. It's a flexible less prone to fracture stent made of nitinol that you unsheath. Okay, you don't expand it with a balloon. You unsheath it. The catheter, the stent catheter, is you unsheath that stent catheter, and the stent will expand spontaneously. Will take its pre-planned form without any ballooning. That type of stent is less prone to fracture, and it has less radial strain, but it's less prone to fracture. And that's the one we use in the SFA if needed. So for SFA, CFA, and popliteal, the basic treatment is one of those two: balloon angioplasty followed by drug-coated balloon, or atherectomy, such as the one I use most is directional Hawk atherectomy system, or orbital atherectomy if heavily calcified. So you do atherectomy, then you follow that by angioplasty and drug-coated balloon. So either one of those two, depending on the complexity. The more complex your disease, probably the more you need to do that second one. And that's my preferred one, based on some data, preferred longer-term strategy. Also less risk of dissection than this strategy, especially when you're using the Hawk system. So we reserve stenting for area with poor atherectomy and angioplasty result, particularly try to avoid stenting in the common femoral and popliteal area that have high fracture risk, bending area. Also, those are bypass sites area and area of access. So you want to try to avoid stenting in this area at all costs. Okay. So those are the two atherectomy systems. There is laser atherectomy can be used for in-stent restenosis. Actually, laser atherectomy is not proven to be useful in in-stent restenosis of the coronaries, even though a lot of people use it. In the coronaries, it's useful for stent under expansion, not for neointimal hyperplasia. It's never been proven to be useful for that. Whereas it is proven to be useful for SFA in-stent restenosis. It is useful for neointimal hyperplasia. So if you have in-stent restenosis, I would use laser atherectomy and drug-coated balloon. For tibial vessels, we also use typically atherectomy. They tend to be very calcified, so I frequently use orbital atherectomy. We can use also, we follow that by balloon angioplasty, usually not a drug-coated angioplasty. It's not available for small vessels. And we can do stenting. There are no specific stents for tibial. We can do coronary stenting, which are balloon extentable and can be fractured and crushed. But the tibial vessel, unlike the femoral, are not subject to a lot of bending and torsion and elongation. So focal coronary DS is safe and has good longevity in those vessels. This is an illustration of that Hawk directional atherectomy. It's like a blade, like a shaving blade. You shave in one direction and you eventually shave in all direction, in 4 quadrant. You shave the plaque in 4 quadrant. And the way it works, it shaves and it packs into the distal cone. It shaves and it packs. It's again like a shaving blade, shaves and back into the distal cone. Hawk 1M, it goes through a 6 French sheath, is the one I use for SFA. So what is a self-expanding stent? A self-expanding stent is a stent made of nitinol, which is a material resistant to deformation and tends to retain its shape. It's also resistant to kink. The stent is collapsed, tucked inside a 0.035-inch catheter, but it keeps the memory of its expanded form. So you advance it into the vessel, then you unsheath it. It has a screw mechanism that allows you to unsheath it. And as you unsheath that catheter that's over it, the stent expands and takes its form. And it takes its natural design and size. It's very flexible, it's resistant to fracture, but it does not have a good radial strain. That's why it often ends up being underexpanded in heavily calcified vessels. And that's why it's important to prep those heavily calcified vessels with atherectomy in order to allow that poor radial strain stent to properly expand. That's also why those stents are sized as a +1, meaning if the vessel is 5 millimeter, you often use a 6 millimeter self-expanding stent. And despite that deformation resistance, they have about 5% fracture rate. There is one brand of self-expanding stent, Supera stent, which is a better self-expanding stent. It is more flexible than the standard self-expanding stent with very low fracture rate of 0.6%. Yet despite that extreme flexibility, it has much more radial strain, up to 4 times more radial strain than the standard stents. They are a little harder to deploy and they need very good vessel preparation, but that's probably the best self-expanding stent. So another idea I want you to know is sizing. How do you size your balloon and stent in peripheral interventions? There are standard, typical diameters for those vessels, and I want you to know those. That will provide you a great guide during your interventions. So for iliac arteries, in general, the size of your balloon and balloon expandable stent is 7 to 8 millimeter in women, 8 to 10 millimeter in men. Of course, it varies. Common iliac is a little bit larger, but those are general averages. When you're using self-expanding stent, you add to those sizes +1, or you add to what you estimate as the vessel size, you add to it +1. So if the vessel is, you think 9 millimeter, you need to put 10 millimeter self-expanding stent if you're choosing to use a self-expanding stent. For the SFA, you need to know that number. Overwhelming majority is 5 millimeter diameter with 5 millimeter balloon and a 6 millimeter self-expanding stent. Again, self-expanding stent, you do +1 to the vessel caliber. So this is, memorize that, very important. 5 millimeter SFA, 6 millimeter self-expanding stent. For Supera stent, the sizing is more fine. And generally speaking, you size your balloon 1-to-1 to what you think the vessel size is, and you add a +0.5, not +1. So if your vessel is 5 millimeter, you use a 5.5 Supera stent. Otherwise, that Supera stent will elongate and will end up landing in an area where you are not planning on landing in. For example, if you use a Supera stent of 6 millimeter in a 5 millimeter vessel, and the length of that stent is 10 centimeter. So if you put a 6 millimeter in a 5 millimeter vessel, that 100 centimeter will elongate and it will end up being 120, 130 centimeter, and it may land approximately where you don't want it to land, like in a common femoral artery. So that's the Supera stent. Atherectomy devices, we have the Hawk 1, Hawk 1M, the typical one that I use, 4 to 7 millimeter vessels. So one size fits all. It goes through a 6 French. There are some older iterations that are stiffer and harder cutters that go through 7 French sheath. Then the CSI solid or classic crown 1.5 millimeter goes through a 5 French sheath. Popliteal arteries in general about 5 millimeter. It could be 6 millimeter in some larger patient, but you remember a number 5 millimeter, kind of close to the SFA. So SFA and popliteal about 5. Iliac 7 to 8 in women, 8 to 10 in men. Tibials, the proximal tibials are 3.5 to 4 millimeter. I tend to err on the 4 millimeter side of those. Distal is about 3 millimeters. You use a CSI crown of 1.25 millimeter, whether micro, soft crown, or solid crown, but 1.25 millimeters. So I will go back to access after giving those ideas. To summarize in a way and elaborate furthermore, I would say that there are 5 access options in the periphery. We've discussed the femoral access, whether standard, retrograde femoral access or antegrade access, particularly for tibial interventions. We also have retrograde popliteal and distal SFA access, very important access. I won't explain it this session. It used to be done via prone positioning. People used to use that popliteal access for complex SFA. If you cannot cross it, you can do cart and you can do tibial access for it, like I explained. But in the past, and it's still as of now, you could also use popliteal access instead of tibial access. people used to use a prone. They used to put the patient on his belly and stick the popliteal this way. But I recommend against it. By today's standard, we can do popliteal access in a supine position, stick the popliteal from the side with the knee a little frogged and raised, okay? But I'll explain it in another session. So the fourth axis is the radial axis, and the fifth axis is the retrograde tibial axis. Okay, so those are the 5 axes, and you can combine several of them. Radial can be used as a standalone axis for iliac and SFA disease, including complex SFA and iliac CTO, but not very complex. So you can use it for SFA CTO as long as it's not very heavily calcified SFA CTO, because then you use a lot of support and pushability. And so it may not work in those cases, although you can do combined radial tibial strategy in those cases. But anyway, so radial can be used as a standalone strategy. It can be used as a supportive strategy for CART in SFA and iliac technique, especially in iliac technique. You can use it antegrade as an antegrade axis and retrograde femoral axis to do CART in complex recanalization. But keep in mind, it can be used as a standalone revascularization axis, and we're using it more and more. So tibial axis, when do we use it? I mentioned it. So we use it in SFA recanalization, particularly combined with a crossover femoral or radial. We use it to facilitate crossing and for reverse CART. Eventually, you'll have to finish your procedure from a femoral axis or radial axis, most typically. You can use the tibial axis also for infrapopliteal recanalization. You can use it again for retrograde crossing and reverse CART, then finishing via the femoral axis. So you use those retrograde devices to cross, then you snare and finish from a femoral axis. Or you can use it as a standalone crossing and treatment strategy for tibial vessel. My preference for tibial axis, in order to keep the sheath size small, is to use it more as an adjunct crossing axis, not as a treatment axis, as a final treatment axis. So basically, I use it to cross, but then I finish the procedure from above. We snare, get that wire, and finish our procedure from above. I don't try to balloon and stent and atherectomize from the tibial axis, typically, but you can do that. And I will show you here what sheath do you place in those flimsy tibial vessels. So if you want to use 0.35-inch catheter and wire system, you typically have to place either a 4 French sheath or a 5 French slender sheath for like adjunct SFA popliteal crossing and reverse CART for SFA popliteal. You can also use 4 French sheath for infrapopliteal, not typically though. For infrapopliteal, I just use a smaller sheath, but you only use a 4 or 5 French slender sheath for infrapopliteal recanalization if you're planning on fully treating that tibial vessel from the tibial axis, okay? So most typically, to keep it simple, when you're using 0.35 French catheter and wire system, to assist in SFA crossing, we use 4 French precision sheath or 5 French slender sheath. When we're using the tibial axis to assist tibial recanalization, we use something smaller. We use the 4 French micropuncture sheath, which is actually equivalent to 0.8 French inner diameter sheath. That's what we use. And through this, we advance the 0.14 or 18-inch Cook CXI catheter and wires to assist, to retrograde across the tibial and assist in the recanalization. Okay, so tibial, you only need a tiny sheath. For femoral, you need this larger sheath, 4 French, 5 French slender for those 0.35 devices. Try to finish from above just to avoid putting big sheath in those tibial and injuring those vessels. By the way, even for SFA, you can use that micropuncture sheath and try to use 0.18-inch system to recanalize the SFA. I will describe how to, just briefly, how to access those tibials. So when I say a tibial access, what am I talking about? I'm talking about accessing the anterior tibial, the most commonly and easiest to access, or posterior tibial, or peroneal at the ankle, all those at the ankle level, or dorsalis pedis at the foot level. All those axes are done via ultrasound, except the peroneal, for me at least. So by ultrasound, as it is in radial, you see the artery surrounded by two veins that can collapse. You always see that image, okay? Eyes and a nose, and you stick this. So the peroneal is the only one I don't stick via ultrasound. I stick it via fluoroguided, but it's the axis that is least commonly used. So this is a view of the foot. When you stick the anterior tibial, you feel the tibia and you image lateral to that tibia, and you look for that anterior tibial artery and you stick it with ultrasound guidance, seeing that image. The posterior tibial, you have to frog and externally rotate the leg, and you stick it around. You feel the malleolus, you scan behind the malleolus and a bit above it. I scan and I pick a spot to stick it, okay? We stick retrogradely. So we put our wire and needle this way and our sheath this way. The peroneal, I don't stick it like they describe here. I stick it actually like this, the peroneal. I stick it from anteriorly, from lateral to the tibia, from this area, the anterior compartment. I stick it through and through the interosseous membrane into the peroneal using fluoroguidance. So I use an ipsilateral ipsilateral view that position me anteriorly on top of that peroneal artery. I make my needle, my micropuncture needle, in line with a roadmap peroneal artery, in line with it, parallel on top of it. Then I stick it. And I can use a contralateral view to see myself going and hitting it. How far am I from it? But the ipsilateral view is most important to put your needle in line with that peroneal. That's actually the same technique you can use to stick the anterior tibial fluoroscopically, but I suggest against it. You should use ultrasound. It's safer and more and better. Okay. I have two more slides that actually took me a long time to put together. Here's the thing. While for coronary balloons and stent, we focus on diameter and we focus just on diameter of the stent and the length of the stent. In the periphery, it's far more complex. You have to think, what access or access combinations do I need? What guide wire system? What French sheath? And what's the French size of the telescope guide? And what can I fit through it? And very importantly, what shaft length and reach, especially when you're trying to do radial recanalization. So I've put together two slides for you. One is the devices we use through femoral recanalization, and another one is for the devices we use through a radial recanalization. Okay, so these are the devices we use for femoral recanalization, and again, I split them into 0.35 inch and 0.14 or 18 inch. And I explain those devices will go through which sheath and what is the length of those devices. Most of them, typically, they are over the wire, by the way. Okay, so we have 0.35 inch support catheter. Navicross, it has this advantage of even being 0.35 inch, it goes through a 4 French sheath. The other ones go through a 5 French sheath and they come up to 150 centimeter shaft. 0.14 or 18 inch support catheter, they go through a 4 French sheath or even 4 French micropuncture sheath. So when you're doing tibia recanalization through a 4 French micropuncture sheath, that Cook CXI becomes very handy because it goes through a 4 French micropuncture sheath. For 0.35 inch balloon, we use a they go through a 5 French guide system. Whenever I say 4 French, I'm saying sheath. Everything I refer to here as 4 or 5 French is sheath. So 0.35 balloon, they go through a 5 French sheath system. 0.14 or 18 balloon, they go through a 4 French sheath system. And they are usually 150 centimeter, but there is a special one by Medtronic that is the shaft of which is 180 centimeter. It can come handy if you're doing up and over to the distal tibial to have that 180 centimeter shaft balloon. Again, when you're using a 14-inch system and thinking infrapopliteal, the shaft length becomes extremely important, particularly when you're doing, again, crossover. You want something to reach, especially in a tall person. So self-expanding SFA and iliac stent of 35-inch, they go through usually a 6 French system. There is a special one that goes through a 5 French system by Medtronic. Balloon expandable iliac stent, they typically 6 French, although for big sizes you need 7 French. A drug-coated balloon, so the classic one, Impact, is a 6 French, but you have Lutonix that goes through 5 French, and you have Ranger, which is an 018-inch drug-coated balloon by Boston Scientific that goes through a 5 French. And it has a longer shaft in cases. It can come handy in short patient if you're doing radial access, but even 150 is not enough in radial access, except if somebody is very short, meaning, you know, about less than 155 centimeter in height. So atherectomy, that's about the only system where you absolutely have to use 014-inch in the SFA system. So directional atherectomy, Hawk 1 and Hawk S, they require 6 French system, any 014-inch wire. Orbital atherectomy, on the other hand, requires less French, 5 French, but it needs a special wire, the Viper wire. Now for radial, I'll give you the same slide, but for transradial maneuver. So radial, there is, of course, the issue is reach with radial. The distance from the left radial access to your left common, to the common femoral artery, left or right common femoral artery, is about 125 to 135 centimeters. It's important to memorize this. The distance from the left radial to your adductor hiatus is approximately equal to your height. So if you're 170 centimeter in height, the distance from here to here is 170 centimeter. This is extremely important to know. That has been my personal observation that I published multiple times in several papers. So it's extremely important to know for you to plan your procedure and to know what catheter I need to do and whether you can balloon that lesion and what balloon shaft and catheter shaft you need. Okay, so important to memorize this. Also important to know we most often use left radial access because right radial is a longer distance. It's about 10 to 12 centimeter longer distance. Also, we don't like to position our sheath across beneath that carotid artery, beneath the innominate and the left carotid artery. So this one is safer because you don't put it beneath the supra-arch vessels. So that's why we tend to do left radial access for those two advantages, potential stroke risk and reach. So those are the devices we use from, those are specific radial to peripheral devices. When I started doing it, and I was, you know, one of the first to use routinely radial to peripheral access, I used to use as a sheath, instead of sheath, I used to use guide. The cord is 6 French multipurpose guide, which comes in 125 centimeter. The multipurpose, that 6 French multipurpose guide is like a 5 French sheath. So you have to realize the limitation of what can I fit through a 5 French sheath. So a lot of the stent would not go through. So this is where I learned what goes through a 5 French sheath. Okay, so that's one. But now we have something better. And back then I also used 7 French multipurpose guide, which is will be like a 6 French sheath. The problem is that you could not advance a standard 6 French sheath from a radial, long standard 6 French sheath. One, they were not available long enough. Two, those standard sheaths create a lot of spasm and you cannot advance them through a radial. You cannot advance a standard long 6 French sheath through a radial. It will get stuck. You will not be able, if you get to advance it, you'll not be able to take it out because of severe spasm. Okay, so nowadays we have the Terumo 6 French, very slick hydrophilic slender sheath, R2P, radial to periphery, 119 and 149 centimeter. Again, for reference, you can position it here, 119 for iliac intervention, 149 centimeter, you can use it for SFA interventions. and popliteal interventions. So this is a 6 French slender sheath. The outer diameter of this is like a 5 French sheath, a very slick 5 French. So the outer diameter of this is fairly small. And I haven't had much spasm issues with it. So now in terms, you need very long wire. The 300 centimeter that we consider long wire is not good enough when you're doing exchanges from a radial access. You need those wires. So Terumo has manufactured special wire, 350, 400, 450 centimeter glide wire, soft or stiff, straight angle or J. Now for 014-inch, the only wire that comes long is the wire done by the orbital atherectomy CSI company. It's the Viper wire, 475 centimeters. For the 035-inch support catheter, there is only one company that makes it. And that to me was the biggest limitation for transradial SFA interventions. When we didn't have all those, that was the biggest limitation. I was able to get sheath and wire into the SFA, but I couldn't get a support catheter. And you absolutely need a support catheter in peripheral intervention to be tracking your wire. So that was my limitation. And now finally, it took a while to have this. We finally have a support catheter. All the support catheter like Quick Cross and Navicross come up to 150 centimeter. That's the only one that comes to 100 centimeter. Now, all 35-inch balloons and other balloons, the big one is the special devices by Terumo, which tend to be monorail rapid exchange, and they come in 200 centimeter shaft. They can be used to treat SFA as well as iliac. And again, 035 to 014-inch. This one is manufactured by Bard. But anyway, we have them available. Then you have 035-inch self-expanding stent. The only real one is the rapid exchange by Terumo. It's 6 to 8 millimeters. And you have, so we don't have a balloon expandable one. So if you want to stent in iliac, you have to use a self-expanding one, which will be a problem if you have ostial common iliac to stent from a radial access. Okay, it's also the diameter doesn't go beyond 8 millimeter, and for common iliac, you may need something bigger. You frequently need 9 or 10 millimeters. Anyway, another system can come, the 5 French Intrast Medtronic can also be used, but it's shorter. It can be used for iliac. There is no drug-coated balloon that has long enough shaft. The only one is the 150 centimeter Ranger, but that, like I said, is only useful in shorter individuals for maybe proximal SFA. The atherectomy system, the only one that comes that long is the orbital atherectomy system, the same one that manufactures Viper cath and the Viper wire. And they have the CSI orbital atherectomy can reach 200 centimeters. So you can treat basically all length of SFA up to an individual who is 200 centimeter in height. All right, so I suggest you to print those 2 slides, this one and that one as well, actually, and keep them with you as you're planning your procedure to understand how to navigate sheath size and catheter shaft length and reach. And I would suggest you print that slide as well, the summary slide of stent and balloon diameter at various disease segments. Any questions regarding those interventions?
Well, this was great, Dr. Hanna. Thank you so much. Just wanted to see what your thoughts are like for distal tibial access, like just going sheathless. What are your thoughts on that?
Very good question.
And how do you close if you are using sheath, like just a matter of pressure, I'm guessing?
Yes, very good question. So one, I strongly recommend against sheathless access. So when you do sheathless access, you're trying, the people who do sheathless access, you're trying to advance the 035-inch catheter and wires. Instead of putting a sheath, you're trying to advance them without any sheath, okay? So to avoid upsizing the size of the hole, because when you put a sheath, you're putting a larger size hole. I used to do that actually when I first started to do tibial interventions. I get away from it. My concern is as you're pushing, so you're using 035 catheter and system to cross a complex SFA. the reason you're using those is to cross a complex SFA that you couldn't cross from a crossover femoral technique. So by definition, it's a complex SFA. You need a lot of push, okay, a lot of knuckling and pushing and re-entering. You tend to push so much, and I think you end up, by doing all those maneuvers, you end up injuring the entry site through your pushing. You end up probably theoretically injuring it more than putting a sheath. Okay, there is a theoretical risk of tearing that vessel with your push. And actually, not just there is a risk of injuring the vessel across its length, that tibial vessel, not just at the entry site, because you're pushing with no support to stabilize your sheath, your catheter at the entry site. So I do hate not using a sheath, and I steer away from it. I use a 4 French precision sheath. Now, in cases where you're doing tibial recanalization, that 4 French micropuncture sheath is really very small outer diameter. It's fairly safe, and I would suggest using it as well. It will provide you with support, and I think at the end, it's probably safer for the vessel. I've pushed so much, and I felt I've bent so many of those tibial accesses, and again, maybe tibial vessels, that I steered away from doing it anymore. So I do use sheath. Also, by the way, for that idea, just know what sheath to use. I mean, again, if you're recanalizing tibial vessel, use just a 4 French micropuncture sheath and try to finish from above. Don't try to finish it from below. For tibial recanalization, that 4 French sheath micropuncture, which is like 2.8 French sheath, is all you need, unless you decide to finish from below. If you decide to finish from below, meaning do atherectomy from below, put a drug-eluting coronary stent and balloon from below, then you will often need to put that 4 French precision sheath or 5 French slender. But to protect it, try to finish from above. If you're worried, you can, for SFA, you can at time try this an 018-inch system and try to cross it with an 018 Cook and glide wire to do that retrograde antegrade with that. So you can. The problem, you cannot advance balloons through this except coronary balloons. None of those balloons that I described here would go, where is it? Yeah, none of those balloons would go through a micropuncture sheath except coronary balloons. So in terms of hemostasis, so if you're using, the best technique, to give you an idea, the best technique is to use the TR band. And that's the one that's the technique I've done. So I've put a TR band and I leave it on the sheath, and if I inflate enough to achieve hemostasis. A lot of time I achieve hemostasis just by the tie itself, without having to put air in it. But I put barely enough air to achieve hemostasis. I keep it on for about 1 hour. For the posterior tibial, I sometimes keep it up to 1.5 hours. So I keep it on as it is for 1 hour. Then I deflate, and I typically deflate fairly quickly. I try to deflate it fully, or at the very least within 15 minutes, be fully deflated. Okay, so that's how I do it, typically with a TR band. There is one technique, again, since we often use tibial vessels as an assist rather than a standalone access. So after you do your TR band, you still have your femoral. Do your TR band before you take your femoral devices or radial devices, and do an image, a distal image through those devices, femoral and radial devices, and see that radial band, that your TR band over the tibial vessel is not occlusive. So see that your contrast is still seeping through. So that's one thing you can do. Another thing you can do to ensure that you're not occluding the tibial vessel is do ultrasound below your tibial band, below that TR band that you place over the tibial. Do ultrasound below and ensure that you have a waveform. Okay? So to answer your question, TR band, as little as possible to achieve hemostasis for 1 hour, maximum 1.5 hours, then I deflate it fully. And before that, as you put it on, verify there is flow, whether via your angiography, femoral angiography, or via ultrasound Doppler waveform.